Hello, my name is Dr. Alan Kerry. I'd like to welcome you to another podcast from the South Essex GP training website. With me I have Dr. Sunil Gupta, and we're going to discuss some possible ideas to save money in health services. So Sunil, some of these ideas seem quite sensible, but there are others which are unusual or going to be very controversial. Why have you included ideas which are going to annoy a lot of people?
These ideas are included to stimulate discussion and bring about the formation of hopefully better ideas. As a disclaimer, I should say the unusual or controversial ideas should not be taken as official policy of any organisation that I'm associated with.
Okay, the ideas are in four groups, which are policy changes, broader health, cutting costs, and different practices. So in the area of policy changes, can you go through the ideas about alcohol and cigarettes, pay and pensions, autonomy, hours worked, adverts, targets, abroad, and the tariff?
So for Part A, which is policy changes, that includes things like alcohol and cigarettes, and possible ideas include increase the cost of alcohol, ban adverts for alcohol and do not allow supermarkets to sell alcohol, and consider only allowing the sale of cigarettes in pharmacies. In pay and pension, some possible ideas are every full-time equivalent worker in the NHS to get a pay increase of £500 a year for the next 3 years, so that will involve lower paid workers benefiting more. Getting UK qualified doctors to have a pay cut of 2% of their salary to acknowledge the cost of training them, and decrease the pension benefits of all staff earning more than £30,000 a year by 5%. In the area of autonomy, you can have things like total fund holding pilots and allowing a greater number of NHS organisations to keep any money which is not spent at the end of the financial years. For hours worked, an idea is to increase the number of hours junior doctors are allowed to work from 48 hours a week back up to 55 hours a week. For adverts, the idea is allow companies to pay to advertise on the sides of ambulances and on the uniforms of staff. And for targets, the ideas are reduce the 4-hour treatment target in accident and emergency, allow the increase in waiting times for elective operations, and decrease the number of patients treated for elected operations in private hospitals paid for by the NHS under the choice agenda. In terms of abroad, the idea is for the NHS to purchase operations to be carried out in foreign countries where this is cheaper but has no worse clinical outcome, and to decrease the cost of NHS Direct by having more staff which are working from call centres which are abroad, and for a tariff to reduce the price of tariffs that hospitals charge by 3% a year for the next 3 years.
The second group of ideas is in the category broader health and includes smoking-related diseases, cardiovascular disease and prevention. Can you give us a list of these ideas?
So these are much less controversial. For smoking-related illnesses, it's investing in helping people to give up smoking, thus reducing the number of smoking-related diseases. It's reducing the number of hospital admissions with infective exacerbations of chronic obstructive pulmonary disease by improving its management in the community. For cardiovascular disease, it's reducing the number of patients developing heart attacks and strokes by improving the management of diseases like hypertension and diabetes, and having good access to angioplasty for heart attacks and thrombolysis for strokes. And for prevention, it's ensuring there's a high uptake of immunisations, developing innovative ways to reduce the number of children becoming obese, having good access to cognitive behavioural therapy for patients with anxiety and depression, and ensuring there's good access to genitourinary services.
The third group of ideas is about cutting costs and includes energy efficiency, leases, medication and reducing spending. What are the ideas in this area?
For energy efficiency, it's greatly increased the effort to make the NHS more energy efficient. For leasing, it's increased the sale and lease back of NHS property, vehicles and equipment, and renting out spaces in hospitals to alternative health practitioners. For medication, it's increasing the amount of medication reviews carried out to reduce the number of unnecessary medications being prescribed. It's ensuring doctors prescribe cheaper generic drugs rather than branded ones, and increasing the prescribing of the low-cost statins. It's banning the meeting of doctors with pharmaceutical drug representatives, and it's increasing the cost of prescription charges in England by 5% a year above inflation. For reducing spending, it's reducing the spend on information technology and on the Department of Health headquarters by 10% a year for the next 3 years. Decrease the money spent by the NHS on management consultants by 50%. Decrease by 10% the number of new medical students. Reduce by 10% the money spent on units of dental activity, IVF treatments and on PMS general practices, and decrease the amount of money spent on patient transport, DASI centres, GP extended hours and independent treatment centres.
The final group of ideas is about different practices and includes avoiding duplication, thresholds for treatment, less variation, patient safety and improved cost effectiveness. What ideas are there in this area?
For avoid duplication, we have greater sharing of resources and functions, and share back office functions such as payroll and estates management between NHS organisations. For threshold of treatments, it's raised the quality adjusted life year level at which NICE recommends treatment under the NHS. It's also increasing the present threshold of severity of illness at which patients are able to have cataract operations and joint replacements, and it's increasing the gestation by 1 week at which premature babies are treated by special care baby units. For less variation, it's reduced variations in surgical thresholds, in emergency admissions and in outpatient referrals. Reduce the length of hospital stay. Increase day case surgery rates. Invest money to reduce the number of medically fit patients having delayed discharge from hospital. Take measures to try to reduce unnecessary readmissions into hospital. Take measures to reduce the number of appointments not attended by patients. Reduce unnecessary follow-up appointments. Shift more work from hospital to the community, e.g. cellulitis, DVT, etc. And invest in services which increase the percentage of palliative care patients dying at home and that reduce the percentage of births which are caesarean sections. For patient safety, it's copy the improvements in patient safety brought about by the Institute of Healthcare Improvement in the USA. Increase the training of nursing staff in hospitals to identify early those patients who are showing signs of deteriorating, and reduce the rate of hospital-associated infections and the number of patients developing venous thromboembolism whilst in hospitals. For improved cost effectiveness, it's improve the skill mix so care is provided more cost effectively, pay theatre staff in hospitals for activity rather than for the number of hours worked, use GP premises which are closed at weekends to generate income for the NHS, give greater training to junior hospital doctors to increase their awareness of the costs of the medication and the equipment that they use, and provide incentives to frontline staff to deliver more cost-effective care by sharing savings between the hospital and the departments that find the savings.
Would you like to make a personal comment about your perception about how the NHS dealt with tight funding in the past and what may be better ways in the next few years?
In the past, when there was tight funding in the NHS, commissioners often ensured the budget was not exceeded even if the quality of services were greatly affected. The commissioners tended to reduce spending in health promotion and make cuts where it was politically easier, rather than look objectively at the cost and benefits of where money was spent. In the past, hospitals, community services and GPs often thought of the best interests of their own organisation rather than what's in the best long-term interests of the NHS in the area. They often resisted any cuts in the budgets and used patients and media to fight them. They resisted new ways of working, and clinicians often blamed the managers. A possible better way to deal with tight funding in the NHS in the future is clinicians explaining to the public why some tough decisions are being made, a greater emphasis on using cost-benefit analysis, e.g. quality adjusted life years, to make decisions about funding, commissioners and providers working more collaboratively to come up with synergistic solutions which save money and or which improve care, and improving patient safety which will save money and increase quality of care. Other ways would be closer working between the NHS, local councils and the third sector to come up with better solutions, using the good ideas from elsewhere, greater emphasis on disease prevention, and everyone thinking what's in the best long-term interests of patients and the whole system rather than what benefits their own organisation short-term.
This idea of the greater benefit for the most people is expressed in game theory, and I think the phrase is a Nash equilibrium, a better Nash equilibrium where everybody benefits. Would you like to explain how that fits with some of these ideas?
Yes, because a Nash equilibrium is what is your best response, taking into account everybody else's best response. So if everybody else thinks what's in the best short-term interests of their own organisation, your best response is also to think what's in the best short-term interests of your organisation. But what research has shown that's where leadership can make a difference, because if leaders think win-win and act in the long term, then they can shift it to a better Nash equilibrium where everyone's thinking what's in the best long-term interests of everybody, and you end up with greater trust and openness between commissioners and providers, and you end up the rewarding of behaviour which benefits patients and the NHS long term, which will result, and that's all brought about by the different organisations in the NHS and social services working more closely together.
Thank you. Thank you for listening to this podcast. Both Sunil and I hope you'll listen to some of the other podcasts on the South Essex GP Training website.